Thank you, Stefan. Thank you, Lucas. It is my great pleasure to be with you again. And thank you for the privilege to letting me to have this presentation and to share this presentation with you. I would like to congratulate Lucas and his colleagues from Serbia for managing to organize such a wonderful event with so much great presentation and a spectacular faculty list. It is really, I'm really happy to be part of it. At the same time, I'm a little bit disappointed that this wonderful meeting has to be online, because I do believe the sharing of the knowledge and the personal contact and socializing is also very important. Very important part of our meetings. Can you hear me? Hello?
Yes, yes, we can hear you.
Okay, so you do see the presentation, I
Yes,
believe.
everything is working.
Okay, okay. Then, this is a simple case report of one patient which we operated on recently with a combination of perforating ocular injury and penetrating brain injury with a low velocity non-missile object. And I'll try to be as concise as possible just to reduce the time. I have no conflict of interest to declare. In introduction, we can say that we all know very well that penetrating trauma, brain injury, which are caused by low velocity sharp objects, are a rare subtype of a non-missile traumatic brain injury. Because of its rare pathology among civilians, it is very rare associated with a perforating eye injury.
And I'm chairman on the session, the first session, trauma.
However, optimal management of such potentially fatal injury is still ambiguous and controversial.
I just presented, yes.
The surgical approach are divided into transorbital and transcranial procedures, and personalized and timely surgical intervention should be undertaken dependent on the mechanism and the extent of injury as soon as possible. The orbit forms an easy pathway for low velocity foreign bodies penetrating into the intracranial space and the brain. Therefore, perforating open globe injury is categorized as to be an object incoming from the eye and entering to the another part of orbit into the endocrinial space. Penetrating brain wound and concomitant perforating ocular injury caused by low velocity sharp metallic objects represent a demanding and complex injury which are requiring a multidisciplinary expert approach. Such an injury needs proper preoperative imaging, prompt surgical management, and adequate post-operative care to attain a favorable outcome primarily to avoid a possible infection. Hereby we present a patient with a penetrating brain injury and perforating ocular injury who was undergoing emergency multidisciplinary expert surgical treatment. Cautious inspections were done to determine the grade of ocular presentation and to assess globe stability, as well as anterior and posterior chamber damage, lens violation, and iris laceration. Preoperative imaging, including computed tomography of the head, and CT angiography was selectively performed to assist the preoperative plan. The methods of surgery were divided between cranial and ocular surgery. Cranial surgery consisted of wound debridement, decompressive craniectomy, and removal of only accessible retained intracranial foreign bodies. Ocular surgery, however, consisted of removal of accessible retained foreign bodies from the eye and the orbit, enucleation and pars plana vitrectomy, globe closure, and palpebral stitching. So these were two different procedures performed simultaneously during one surgery. The patient was a 39-year-old who sustained an injury during a mechanical work with a round saw. So a particle of a round saw performed, the round saw was broken, and a particle of the saw penetrating his brain, his endocranial space throughout the globe, throughout the orbit. The left orbital roof was the route by which the foreign bodies entered the brain. And in the setting of open globe, left open globe injury, he sustained a full thickness scleral wound, horizontal laceration extending from the center of cornea temporarily, with uvea and iris prolapse, as well as lens violation. So the entire ocular globe was destroyed. After a meticulous diagnostic, but urgent diagnostics, we understand that a sharp metallic object was lodged in the left parietal lobe, subcortical, but perpendicular to the parietal lobe. I'll see you how it looks, how it looked like. So as you can see, it was a very impressive and very devastating injury, with a scalp injury, ocular injury, and of course, brain injury. Multiple bone fragments and metallic foreign bodies were retained in the lateral extra-orbital aspects of left orbit and in the left lateral rectus muscle, and above as well as behind the destroyed globe. When we performed a CT of the head, then we can see that a blood-filled penetrating wound impact cranial throughout the brain parenchyma was filled with retained foreign bodies, bony fragments, and a small amount of hair. A sharp metallic object was retained subcortically and lodged in the left parietal lobe perpendicular to the bone. So this is how it looked. Sharp metallic object, but it was perpendicular to the bone, and the devastating effect was obvious at the primary site. We have also performed a preoperative CTA just to eliminate, to be sure that there was no obvious vascular injury. And after that, we have decided to operate on. We performed a huge decompressive left-sided frontotemporal parietal craniectomy urgently. Left transorbital penetrating wound entering the skull base was repaired. A huge and sharp triangular metallic foreign body, actually a slice of a round saw, was identified by finger palpation and being lodged in the left parietal lobe just subcortically. We have managed to successfully remove it under direct visualization and with a minimal cortical damage as well as bleeding. Following a repair of the globe injury, eye lithorum was also repaired and palpebral stitching was performed by ocular surgeon. So these are the images: ocular injury, the injury of the left orbit, complete destroyment of the left globe, and some metallic objects removed from the orbit. The lens violation is also present. Here we can see from inside the brain, from endocranial space, the entry wound. This is a roof of the orbit where the metallic object entered into intracranial space. And this is the procedure of removal of the foreign body. As I have said, it was lodged just subcortically on the left parietal lobe, and it can be identified only by palpation. So a small cortical excision with minimal bleeding was performed just to remove this particularly huge and sharp metallic object, as we can see here. To prevent infectious complication, which is a real threat after such an injury, a prophylactic administration of broad-spectrum antibiotics was applied, as well as the orbit, and the orbital wound was irrigated with antibiotic saline. Although the dura was left wide open after the compressive craniotomy, patient did not have a reported CSF leak post-procedural, as well as any signs of CSF infection. He was discharged 45 days after with a moderate right-sided motor weakness, left facial nerve central palsy, and motoric dysphagia. At a 6-month follow-up, and after protracted long-term physical rehabilitation, motoric and speech deficit was substantially diminished, and overall functional outcome was much improved. Unfortunately, the vision to his left eye was completely and permanently lost. This is how his CT looks at day 2 post-injury, after the decompression craniectomy, and with the injury canal filled out with some debris and some blood. On day 45, just before the discharge from hospital, we can see that there was no blood, endocranial blood retained. This is a bone fragments that we didn't insist to remove, and this is a slight brain edema. And finally, at the 6-month follow-up, the same CT scan shows that the edema was subsided. There are also some encephalomalacia and retained bodies, but ventricular system is in a medial position and without signs of hydrocephalus. So we were very satisfied with this final CT at 6 months. And this is our patient just before discharge. We can see the palpebral stitching, the wounds, the compressive craniectomy, and here contralateral peripheral central facial paresis as a consequence of the injury. In conclusion, we can say that although relatively rare and less destructive than missile injury, non-missile low-velocity transorbital penetrating brain injury is dangerous and potentially lethal when vital neural and vascular endocrinal structures are involved. Hence, the presenting pictures of such brain injury may be discouraging. The current management tendency is toward a less aggressive debridement of deep-seated bone and metallic fragments, and less aggressive and more aggressive systematic and intravitreal antibiotic prophylaxis to improve the outcome. The management of such an injury can be satisfactory when proper clinical and radiological evaluation are applied and aggressive surgical techniques are performed as early as possible. And what I found is very important is also the fact that a multidisciplinary approach is a prerequisite in achieving a favorable outcome. That will be all. Thank you very much for your attention. Greetings from Zagreb, Croatia, and hope that we will soon meet each other in live. Thank you very much.